Now, I've just returned from the 11th Sheffield Gastroenterology Symposium, and usually the only feedback you get when a colleague returns from a symposium is perhaps a couple of photographs of smiling friends. But I think that we should do better than that. I think we can do better than that. And I therefore vow to try to submit conference report whenever I go away at a symposium. The idea is that others who perhaps decided against increasing their CO2 footprint can also benefit from the wisdom gained by presenters who no doubt spend many hundreds of hours trawling through the published evidence only to present it in a pleasant format for the benefit of the few who actually attend at the conference. I think we can do better. I can do better. Now, the day started with Dr. Saeed Din from Derby, who gave a presentation on stent therapy in colonic Crohn's disease. He highlighted Dr. Navinathan's meta-analysis of some 1163 dilatations from 2006. You might be familiar with this publication. It was in Surgical Endoscopy, volume 30, issue 12 pages, 34 to 43. Anyway, this meta-analysis showed that although the initial success rate was great at about 90%, 56% of patients required 2 or more dilatations, and up to 18% had a complication. You might also remember, and this is the only thing I remember from that paper actually, is that strictures shorter than 4 centimeters did much better than longer strictures. And of course our dilatation balloons are about 4 centimeters long, so the moment you have to kind of tunnel in and do segmental kind of dilatations, then you're on a loser basically. Anyway, at Derby, they had started placing partially covered removable Hanaro stents. These are, I think the model number is HRC 2080230. They're sold by Dagmed, by the way. They've done 28 patients to date, and he described the data, and it's very highly selective. I think there was an initial pool of 245 patients with strictures, and that was whittled down to 28, so it's clearly highly selective. Anyway, the initial success rate was the same as for a standard dilatation. They had 4 adverse events, that's 15%, very similar data to dilatations. They had 4 stent migrations, and 4 patients complained of pain afterwards, and 1 of those had to go for surgery, but there was no perforation apparently at the time of laparotomy. Now, I must admit, I don't really rate esophageal stents for esophageal strictures, so I would be surprised if colonic stents were actually any better, but it'd be great if they were. And the other take-home message from Din's presentation is that those Hanaro stents, they're quite, my initial thought would have been that removing these stents would be a nightmare, but those Hanaro stents got like a thread inside of them that you pull, and that turns them inside out, which of course is a great way to remove any stent. It's always easy to kind of peel it off the wall. Unfortunately, they only come in one size, 20 millimeters, so you can't really use them for that many places. I think they'd probably be too small in the esophagus, for example. Anyway, I really want to see what the results are after about 1 year before I change my practice. After all, those stents are very expensive, and way more expensive than a standard dilatation balloon. And add to this expense the inconvenience to the patient of having to come back a week after the first colonoscopy, have a second colonoscopy, this time to remove the stent. And also then add to the cost of the stent is the cost of a radiologist in this study, because they use a radiologist to actually place and deploy the stent. Someone in the audience actually asked if a radiologist were really necessary, and it makes you wonder, doesn't it? Can't imagine really. Yeah, can't be that difficult, can it? I mean, we're gastroenterologists after all. Then Professor Ishak at Birmingham talked about water exchange colonoscopy. This is where you completely switch off the air pump and just inflate the colon with a small amount of water. He explained that if the views become clouded, you suck out the water and infuse fresh water to kind of maintain views. And on hearing Prof. Ishak, I realized that I've been doing my water exchanges all wrong. You, for example, only infuse enough water to just about see where the lumen is. You don't want to distend the colon at all. And therefore the tip of the scope should be brought up very close to the lumen as it opens up in front of you with a small amount of water, perhaps no more than 300 mils or so to be infused. And if the views get cloudy, you move the tip of the scope up to about 11 o'clock position to kind of free the suction channel on the bottom right hand corner, kind of in the 5 o'clock position, away from the mucosa, so you can kind of suck out the cloudy water and infuse fresh, clean water instead. And he also explained that if the colonic lumen opens up more than just a few millimeters, there's too much water. You have to suck it back out again. And of course, once you reach the cecum, you switch on the air pump again, or CO2, and enjoy the clean colonic views on the way out. He said that it can take up to 100 colonoscopies to get a hang of this, but I don't think. Now next we had Dr. Deepak Joshi, who talked to us about variceal stenting using the Dunny stent. He reminded us of the Bavino 6 consensus report, which does mention Dunny stents, saying that it may well be safer than balloon tamponade. The initial success rate of placing a Dunny stent is around 90%. As you know, the idea is you leave the stent in for a couple of weeks and then the patient should go on to TIPS normally. But of course, not every person is suitable for a TIPS. So it begs the question, what do you do with the others then? And the kit is really expensive. That's the other drawback. It's about £1,400 for the placement of the kit, and then the removal part, the removal equipment, is another £1,000. Just wondering, by the way, why haven't we seen some other product, some other stent product that we can place? It would be really handy to have. Imagine you're scoping the patient under general anesthetic, and the endoscopic hemostasis doesn't seem to be working right, so you're thinking about a balloon tamponade, but they are difficult and somewhat dangerous to place within intubation patients because it's quite easy to inadvertently inflate the gastric balloon in the mid-esophagus. Of course, that's not the right thing to do. It ends in tears. Now, of course, the Hanara stent wouldn't work because it only comes in a single 20mm size, whilst the Dunny stent is 25mm. But why haven't we seen some other stents out there that can help us in this situation? With one of those ingenious threads in the middle, so we can kind of remove it by simply pulling a thread and pulling it inside out, rather than spending £1,000 on some removal kit. I think there's room for industry to kind of help us out here. Anyway, next came Professor Andrew Hoppe, who was talking about full thickness colonic resection using that Ovesco device, which is distributed by Synmed in the UK, I think. Apparently there's a multi-center trial ongoing in this, and he explained that the initial results were quite good, with a 90% success rate in placing the clip, but that was mainly in benign disease. The success rate drops to about 45% if the lesion is malignant, and it drops even further, I believe, if the lesion is larger than 2 centimeters in diameter. He told us that to date there's been an overall of 4% perforation rate and a 2% risk of emergency surgery. The local recurrence rate in benign disease was 15%, which of course is not that different to that of a difficult EMR. And it was then at pains to explain that you need to go on a course before you start using this device, and that it was important never to apply suction, but to rely on the forceps to pull the lesion symmetrically into the cup. Now, personally, I haven't had any great trouble dealing with local recurrences with some aggressive APC. And for this reason, the main use for this device that I can see in Leeds anyway would be for small cancers, perhaps in all people who are too high an operative risk. Now, the problem is that the risk of a perforation is likely to be even greater in early cancers. Imagine that you referred a patient with a small cancer who is deemed very high risk for surgery. You will then have to consider that the risk of a perforation is probably greater than the average perforation rate of this device, which is 1 in 50. Say that you end up proposing a procedure with a 1 in 30 risk of a perforation, which may well require emergency surgical repair. However, remember, this is in a patient who was deemed to be at an excessive surgical risk in the elective setting. What is his surgical risk in emergency setting, do you think? Well, of course, it's going to be exceedingly high. And conversely, if you decide that this patient is too old and too frail or whatever to offer a full thickness resection of his early cancer, well, he's likely to live maybe 3 or 4 years before this early cancer kills him. And of course, if he's that old and frail, he's very likely to die from comorbid disease before he lives another 3 or 4 years anyway. Conversely, if you go ahead and offer a full thickness resection and it all goes wrong, end in tears, you can't close the perforation endoscopically, he ends up having an emergency operation, he may well be dead within days. I think it's very hard to select these patients, and luckily it's up to the lower GI cancer MDT, and they got a job on their hands to consider the correct patients for this device. Now, George Webster was up next, and he's always a great speaker, particularly so when talking about ERCP. He made the point that we should probably do ERCP procedures under general anesthesia for the patient's sake, and also to improve safety and to protect ourselves. After all, deep sedation is usually required in these cases, rather than conscious sedation, and the difference, I guess, is that the patient responds to shouting or shaking only, rather than simply asking in a normal tone of voice. And this was indeed the conclusion at a joint position statement by the BSG, the Royal College of Anaesthetists, and the JAG, General Anesthesia. He then went on to point out that if the stone is larger in diameter than the diameter of the distal CBD, failure is likely. He reminded us that you can't dilate the ampulla above the diameter of the CBD above the ampulla itself, and apparently at UCL they now solely rely on electrohydraulic lithotripsy rather than mechanical lithotripsy to deal with these larger and more predictably more difficult stones. He also talked about the thorny issue of biliary drainage before surgery in malignant obstructions. Remember, in the old days this was a no-no, these patients should go straight to surgery. However, he emphasized that most of these patients now have chemotherapy, of course, before surgery, and that in these cases the placement of a metal stent provides a rapid fall in bilirubin and a longer patency to allow neoadjuvant chemotherapy to downstage the cancer before the operation. Finally, he mentioned hilar strictures, reminding us that you must be 100% sure that the stricture is malignant before considering stenting. Each case should of course be discussed at the local hepatopancreatic biliary MDT, and of course the stent must be metal. Of course, this is to allow drainage of both sides of the liver at the hilum. And he recommended that these cases should probably only be done in high volume centers. His presentation made me wonder though, is there enough capacity in a high volume centers to take on all this extra work, everything under GA, etc.? Don't know if that's the case. Now, Anupam Reg, a research reg from Sheffield, then talked to us about celiac disease. He reminded us to take 4 samples from the duodenum and a further sample from the duodenal cap, which adds an extra 10% power to exclude celiac disease, or confirm celiac disease rather. He skirted around the topic of why we can't rely on just TTG levels to diagnose celiac disease, like the pediatricians do. He pointed to the large number of different assays available in different hospitals, and he made the point that it's difficult to set a cutoff point where the level is sufficiently above the normal range that celiac disease is a certainty, and there's no need for samples. However, they seem to have done this work in Sheffield though, and reported that with their assay if the TGG level is 10 times above the normal upper range, the chance of celiac disease, or risk of celiac disease rather, was 90%. Someone in the audience then pointed out that the pediatricians have managed to issue guidelines in spite of those different ranges of assays, etc. And this avoids doing gastroscopies in kids all the time. Difficult. If they can do it, surely we could do it too. Anyway, Anupam then went on to tell us that you can't really rely on a persistent positive TGG or serum EMA levels to detect patients with persistent villus atrophy from a continued exposure to gluten. I must admit that I didn't know that. It's only biopsies can tell you that. There is hope, though, that in the future there might be near-patient testing for urine immunogenic peptides, and that might be a quick way of diagnosing celiac disease or continuous exposure to gluten in the future. I think that he somewhat ruined his optimistic finish by showing then a video. It was clearly put together by some patient pressure group aimed at the public, basically saying that if you have bellyache, you need a blood test for celiac disease and an endoscopy. And that really annoyed me, because what's the point of having GPs if things were that simple? Now next, Ralph Bishops from Leuven, that's in Belgium, gave the Baden lecture talking about esophageal neoplasia. I'm quite familiar with this topic, but it's worth mentioning a few bullet points. First, if your histopathologist often reports that there is low-grade dysplasia within a patient's Barrett's mucosa, then you will have a very low progression to high-grade dysplasia. Perhaps the progression rate is as low as 1 in 70 at 7 years. Of course, it is for this reason that you should have more than one pathologist confirming the diagnosis of low-grade dysplasia. However, if low-grade dysplasia is a very rare diagnosis at your institution, the risk of progression to high-grade dysplasia or early intermucosal cancer can be as high as 1 in 2.5 at 2 years. And that compares to 1 in 2 to 300 per year if there's no dysplasia at all. He then contrasted the risk of nodal metastases of Barrett's adenocarcinoma with that of esophageal squamous cell carcinoma. Basically, you're allowed invasion into the superficial submucosa with a Barrett's cancer, but the moment that you have an SEC just nudging the muscularis mucosa, you start to clock up a much higher risk of nodal micrometastases. Furthermore, there is also a much higher risk of a local recurrence, and Ralph thinks that this may be due to deep dysplastic glands, which kind of resprouts the unstable squamous mucosa. And for this reason, he said there's absolutely no role for RFA in the management of squamous dysplasia in the esophagus. In my own practice, by the way, the rule of thumb is that if the squamous mucosa is absolutely flat, then there's a good chance of a cure by endoscopic means. But endoscopic resection, that is, if we don't offer RFA for it either. But if there is any thickness to the lesion, it's likely that an early CCC is beyond endoscopic cure. Furthermore, Ralph explained that there's no evidence that EMR is inferior to ESD for Barrett's resections. As you know, this contrasts with SECs, where ESDs are recommended. And Ralph briefly discussed the evidence behind this advice. Apparently it dates back to a study by Takahashi, which was published in GIE in 2010. If you want to look it up, it was volume 72, pages 255 to 64. And in this study, they reported that the local recurrence rate was 10% for Barrett's adenocarcinomas removed, or squamous cell carcinomas rather, removed by EMR, but this dropped to 1% when the SCCs were removed by ESD. But he pointed out that this study was not randomized. Instead, the EMR cases of the study, they were recruited between 1994 to 2003, and then the ESD cases were recruited in 2004 to 2007. Now, I was scoping in 1994, and I can tell you that the views obtained back in those days with those old endoscopes, they were far inferior to the views we had 10 years later. And therefore, the local recurrence rate for ESD is simply because of better endoscopic views with the new scopes that were around 10-15 years later. It had nothing to do, probably, with the method of resection. Instead, more recent evidence put the risk of a local recurrence following an ESD for an SCC at about 1 in 6 at 5 years. However, I suspect that this may be an underestimate, because clearly the full length of the squamous mucosa is likely to be unstable. I mean, after all, it's all been exposed to tobacco and alcohol, hasn't it? Those pathogens don't kind of skip around, it coats the whole mucosa. Anyway, as regards RFA, we all know that the old double hit method with the Halo Express balloons cause too many strictures. If you do this is where you step on the pedal, bang, the balloon, the express balloon deflates, and then you inflate it again immediately and give it another hit. It gives you a 1 in 5 risk of a stricture. It's too high. So the company recommends a 10 joule hit, and then you take the ablating catheter out, you clean the mucosa of all the slough, and then you go down with the ablator again and give it a second 10 joule ablation. And this gives you a 6 out of 7 response rate. However, a single hit, which of course is much faster and easier, give you a 3 out of 4 response rate, which is not that far behind and a heck of a lot easier for the patient and quicker. And this is actually what I often do in leads, unless the patient is having a general anesthetic, of course. Now, the drawback is, of course, that you may have to arrange an extra RFA session to completely get rid of the Barrett's. Moving on, he reminded us about the Vlieberg study published in the April edition of Endoscopy this year, which showed that the remission following RFA probably doesn't really last. After just 2 years, about 1 in 3 patients will have suffered a small relapse of the Barrett's, and in half of these cases, the recurrent Barrett's was again dysplastic. And indeed, the more unstable the Barrett's was before the RFA, the sooner is likely to relapse. It's a cruel paradox, really. And finally, Raf mentioned cryotherapy. Initial data is very limited, but it puts the response rates very similar to that of RFA at about 6 out of 7. We'll get complete cure of the Barrett's. Temporary cure, no doubt, it's going to relapse again, surely. And about 1 in 20 stricture rate with cryotherapy. And this is also very similar to RFA. But he made the point that the main and perhaps the only advantage of cryotherapy over RFA is that it's markedly less painful afterwards. Now, in Leeds, we prescribe something called oxetocane and antacid. It's a local anesthetic that the patient takes 15 mils of 10 minutes before eating and drinking something hot, and we give a 2-week supply of this. It's something that our clinical oncologist has mentioned to me. They give this to a patient who's had radiotherapy to the esophaguses, and it works really well. Now, after lunch, Simon Pander gave us a great overview of nasal endoscopy, making the point that the quality of image was not that far behind that of a standard endoscope. Particularly the Fujiscope got excellent views and also has a slightly larger air/biopsy channel. Of course, the biopsies are smaller, but this doesn't seem to appear to affect the quality of the histopathology. Having said that, currently the BSG does not recommend that Barrett surveillance biopsies are done using a nasal endoscope. Simon then recommended nasal endoscopy for all diagnostic endoscopies, perhaps with the exception of Barrett surveillance, of course, and also recommended it for some therapeutic procedures, such as the placement of NJ tubes, because of course there's then no need to reroute the feeding tube through the nose. I mean, it's just coming out through the nose at the end of the procedure. And also for the placement of stents. He also explained that there's only one firm contraindication, and that is patients with hereditary hemorrhagic telangiectasia. These patients should not be endoscoped using the nasal route. However, he mentioned actually towards the end that even in patients without HHT, there is a 5% risk of nasal bleeding. And Simon mentioned that you need to know how to manage this. And for this reason, he mentioned that you should probably liaise with the ENT department. Shu and Thomas Gibson then talked about safety and quality in endoscopy, and she mentioned some acronyms which I had not heard of before. Have you heard of GIRFT, for example? It stands for Getting It Right the First Time. Must admit that I find this acronym a little annoying. After all, who's ever got anything right the first time around? Anyway, it turns out that the GIRFT program is about disseminating practice from units with better outcomes. The program talks about a shoulder-to-shoulder ethos to disseminate good practice. I remain a bit skeptical. As someone once said, change only seems to happen one grave at a time. But we should try everything we can, of course. Then she mentioned another acronym called ISRI. Is that familiar to anyone? It stands for Improving Safety and Reducing Error in Endoscopy. Apparently, the implementation of ISRI includes an undertaking to prevent incidents, improve training, promote reporting of incidents, promote learning from incidents, and develop support processes. And I do agree that I do think that we learn most from other people's disasters. And it's indeed for this reason that I always upload details of my own debacles onto Friends of Endoscopy. We can all learn from them and perhaps save others from doing the same mistake again. My colleague Ruchid Sud was then talking about stenting. He reminded us that the rule of 3 was actually developed for bouginage dilatations. That's when you basically put the bouginage down, and when you start to feel resistance, you don't go up more than 3 millimeters maximum. Anyway, that's only really relevant for bouginage, not for through the scope dilatation balloons necessarily. He told us that the evidence is accumulating for the injection of triamcinolone, that's Kenalog, 40 mg into recurrent peptic strictures. It does seem to reduce the number of dilatations required and the dysphagia-free period. However, there's lots of unknowns with this, do you inject before you dilate or afterwards? Do you inject in a single place or in quadrants? How deep do you inject? As deep as the muscle propria, or do you try to go submucosally? And how many times do you inject? I mean, after all, the rheumatologist will only inject a joint up to 3 times maximum. There are lots of outstanding questions here, and it's difficult to recommend a therapy that we don't really know the details of, so to speak. He then finished off by talking about the bougie cap, that little transparent conical cap that you could put on the end of an endoscope to dilate up. I think the biggest cap is 60 millimeters. I must admit that I don't really see the point of it, apart from perhaps dilatations in the very high esophagus. Maybe it's helpful there. My friend Massi, that's Massimiliano Di Pietro, was then talking about colonic perforations. This was arguably the most difficult topic of the day because the information is so limited. When is the last time you saw a double-blind trial of colonoscopy with or without a perforation? Anyway, his presentation can be summarized very simply as keep calm, switch to CO2, or perhaps better, switch off the air pump altogether if you made a perforation. Attempt to close the defect. You can perhaps discharge those with small defects. If you immediately close it completely without any contamination of the peritoneum. Others should be admitted for observation and antibiotics, and of course those with large perforations should be sent for surgery. No surprises there then. By the way, this business about switching off the air pump is that if you keep blowing air into the peritoneal cavity, what will happen is that you start splinting the diaphragm, and then you'll find after about 5-10 minutes that the oxygen saturation levels start to drop. So for that reason, if I made a perforation, I immediately take my finger off the air button. Now, Rina Sidhu then gave us an update on small bowel endoscopy and capsule endoscopy. She mentioned, by the way, the Lewis score, which basically is a capsule score which quantifies the villus edema, ulceration and any stenosis seen at capsule endoscopy. And it gives you a score which can be used to predict the risk of flare-up in Crohn's disease, I think both in the short term and in the longer term. She then mentioned a systematic review of small bowel dilatations published in the World Journal of Gastroenterology, which reported that although 46% of patients required more than one dilatation, and there was a 1 in 30 risk of a complication, surgery was actually avoided in 80% of cases, which sounds better than the initial somewhat bleak outline of dilatations that we heard from the first lecturer. Anyway, she then mentioned the PillCam Crohn's. This is a new kind of capsule which has enough battery length and to look both at the small bowel and the colon in patient with Crohn's disease, but I guess it could be used for others too. Apparently there's an ongoing multi-center study in this which compares colonoscopy plus intubation into the ileum with this PillCam Crohn's. And I wasn't surprised to hear that the PillCam Crohn's seemed to find about 15% more lesions, which I can only presume are all kind of situated above the terminal ileum where the colonoscope can't reach. And it begged the question, I thought, shouldn't the comparative group to the PillCam would have been colonoscopy and the standard small bowel capsule? Wouldn't that have been a bit more fair? Anyway, we know that capsule endoscopy is the best way of investigating what's called, what Rina referred to as non-hematemesis GI bleeding. I guess it's actually non-hematemesis, no hemodynamic instability GI bleeding in patients with iron deficiency anemia, for example, following a normal gastroscopy and colonoscopy, top and tail if you like. Of course, the yield is highest in the elderly and those with the lowest hemoglobin levels, but the younger patients can also have cancers, of course, and deserve a capsule study. Yeah, I can see problems, with using a capsule endoscopy to investigate patients in the acute setting, because to maximize the yield, this is an acute hematemesis like GI bleeding after normal gastroscopy. To maximize the yield, you really need to give this as soon as possible after presentation, of course, maybe immediately after the gastroscopy. And this poses challenges. How do you do this? And could you expect people to read the data from the capsule recorder on Saturday morning, for example? It's going to be tricky, I think. And Rina then surprised me by highlighting two separate studies by Rami in Endoscopy 2014 and Ruagnuolo in the Journal of Clinical Gastroenterology 2015, which basically showed that double balloon enteroscopy with APC of patients with iron deficiency anemia, APC of all telangiectasia found, was as good or as bad as what they called natural controls. These are basically patients who had nothing done to them and then simply followed up. In both groups, about 1 in 3 will rebleed every year. It makes you wonder why on earth do we bother to do small bowel enteroscopy and APC of telangiectasia. We should probably rely more on somatostatin analogs and stuff like that. And she then made an argument for using capsule endoscopy to investigate celiac patients with alarm symptoms or refractory celiac, as there's a 15% risk of finding things that you really want to know about, such as lymphomas, carcinomas, or ulcerative jejunitis. Then it was my turn to comment on the thorny issue of post-colonoscopy colorectal cancer. And as it was somewhat late in the day, I angled my presentation away from the National Endoscopy database kind of perspective and which have always been about highlighting the issue about improving detection rate, etc. And instead I aimed it kind of towards the individual endoscopist, basically emphasizing the kind of things you can do to avoid clocking up post-colonoscopy colorectal cancers. At the moment, the plan, well, we don't know really what the plan is, but there's talks of what could be a punitive process with root cause analysis and duty of candor, sitting down and explaining to the patient what could possibly go wrong with the benefit of hindsight, of course. So it basically hinges firmly on local hospitals to strictly apply the kind of guidelines, basically. What other evidence can you go by? But I can see problems with that too. I mean, it's not unusual for me to scope an elderly patient, say 85-year-old patient. I remove a big polyp from the cecum. I did one yesterday. Big polyp from the cecum, piecemeal resection, and I'm sure I've removed all of it. So I would normally probably say, look, Mrs. Smith, why don't you come back, say, next year, and we'll check you out in 12 months' time. But with post-colonoscopy colorectal cancers, you really have to bring this poor lady back, age 86, in about 3 months' time for another colonoscopy, just to make sure that A, there's no polyp growing back, and B, that there's no other lesions that the index colonoscopy missed. Because if he missed something, then you're to blame, even though you purely did a therapeutic endoscopy, it wasn't a diagnostic examination. So it will skew practice, there's no doubt about it, and this is my worry. I can see there being some endoscopies might bow out of doing colonoscopy, and so the capacity might drop, and also an increasing number of patients will have earlier follow-up examinations just in case. So I can see a paradoxical drop in our colonoscopy capacity in the UK if this process is kind of enforced too violently, and then there might be a paradoxical drop in the number of colorectal cancers picked up by colonoscopy rather than. And finally, Professor Sunil Durvani, he finished the day by talking about the serrated polyps. They're no longer, by the way, called sessile serrated polyps because they come in different shapes, of course. So serrated polyps. And he made the point that initially a 5% detection rate of these were recommended as the kind of the benchmark by the AGA, but a recent Conscop study put the figure closer to 14%, so that's probably the real de facto benchmark we should aim for. He also highlighted that MBI doesn't help you in finding these, and the best way of finding these is by dye spraying, and there's no surprises there. In fact, dye spray is the best way of finding anything in the colon, it seems. He also mentioned that the WHO criteria for serrated polyposis syndrome has been simplified. Personally, I have to look this up every time, actually. And basically, I start thinking serrated polyp syndrome if I see one or more 10mm or larger serrated polyp, or more than 20 serrated polyps throughout. And then I look up the WHO criteria and decide for sure. And the other feature which hasn't really found its way into the guidelines is if there's a mixture of both serrated polyps and adenomatous polyps, particularly in a younger person, perhaps below the age of 40 or so. That also makes me very suspicious. After all, a lot of old people got plenty of serrated polyps, which I suspected because their cells have started to inactivate their own mismatch repair gene system, rather than because of some inherited syndrome. Anyway, this is an area for future research, I'm sure. Sunil then mentioned a very handy table published by Ericsson in Gastroenterology 2016. For those who want to look the reference up, it's volume 150, issue 4, pages 895 to 902. And basically, in this table, the 10-year risk of colorectal cancer was kind of tabulated, and basically, you got a 1 in 4. The patient got 1 in 40 risk of colorectal cancer if you find a mixture of serrated lesions and an adenomatous lesion. oddly enough, it was exactly the same figure, 1 in 40, whether you found adenomatous polyps with the serrated polyps, or there were just serrated polyps, or just adenomatous polyps. So the whole idea of kind of adenoma detection rate is beginning to kind of slide, isn't it? Now we're talking serrated polyp and adenomatous polyp identification rate. 1 in 20 of the serrated lesions were there was 1 in 20 risk of colorectal cancer if the serrated lesion was dysplastic. Okay, so that should make you even more kind of concerned. Or if you find a traditional serrated adenoma. Patient with just, according to Ericsson's study, patients with just hyperplastic polyps only had a 1 in 80 risk of developing a colorectal cancer after 10 years. Which presumably is kind of the background risk if you don't have any serrated lesions or adenomatous polyps. The obvious problem is, the elephant in the room, if you wish, is that pathologists find it very, very difficult to distinguish between serrated polyps and hyperplastic polyps. They have criteria, but that's all in the eye of the beholder, and I'm sure the kappa value is terrible. This is all very interesting because currently the average risk of being diagnosed with a colorectal cancer within 6 months to 3 years following a colonoscopy on the NHS is supposed to be 1 in 300 only. Are we then? And that compares to 1 in 80 risk of colorectal cancer after 10 years in this Danish study. Odd. Anyway, I'm actually using these kind of risks when I consent patients about missing important precancerous lesions. I put that on the consent form. You can't consent away kind of your practice, of course, but I put it down there as to emphasize to everyone that if you have a colonoscopy and then develop worrying symptoms, the previous colonoscopy 2 years earlier is not a cast iron guarantee that you haven't actually got a colorectal cancer, that you still need to go to the doctor to get yourself checked out. After all, you don't want to lull your patients into a false sense of security, do you? Anyway, this concludes my report from the 11th Sheffield Gastroenterology Symposium. Thank you very much for listening.